June 1944. U.S. Naval Hospital, Saipan. The young Japanese nurse froze as the American medical officer gestured toward the wounded Marine on the stretcher. Blood seeped through bandages wrapped around his shoulder and chest. His breathing labored. Just hours earlier, she had been hiding in a cave with other medical personnel from the Imperial Japanese Navy hospital unit, certain that capture meant torture or death. Now this tall American doctor was pointing at medical supplies, making a wrapping motion around his own shoulder, then pointing at her, then back to the wounded Marine. The message was unmistakable. He wanted her to treat an American casualty. This moment of stunned disbelief would be repeated 127 times in the following weeks as American forces, facing overwhelming casualties and severe medical personnel shortages, made an unprecedented decision. They asked captured Japanese nurses to assist in treating wounded American servicemen. This request violated everything the Japanese medical personnel had been taught about the barbaric Americans, initiating a profound transformation that military historians would later identify as one of the most extraordinary examples of professional ethics transcending national boundaries during the Pacific War. The Battle of Saipan, beginning June 15, 1944, brought ferocious fighting to the Mariana Islands. American casualty figures mounted rapidly: 3,226 killed and 10,364 wounded. The naval hospital facilities established on the island were quickly overwhelmed. Medical personnel worked 20-hour shifts, struggling to keep pace with the constant arrival of wounded Marines and soldiers. Navy medical records from June 1944 document that some field hospitals were operating at 287% of designed capacity, with critical shortages of trained nurses. Japanese military propaganda had prepared medical personnel for the worst. Official Imperial Army training materials recovered after the battle contained explicit warnings that Americans took no prisoners and subjected captured medical personnel to humiliation before execution. Documents recovered from Japanese medical officers' quarters included specific instructions to commit suicide rather than fall into American hands. Most Japanese nurses captured on Saipan had witnessed or participated in the island's civilian mass suicides, where approximately 1,000 Japanese civilians jumped from Suicide Cliff and Banzai Cliff rather than surrender. Against this background, the American request for medical assistance seemed incomprehensible. Navy Lieutenant Commander James Vader, senior medical officer of the 2nd Marine Division, documented the first interaction in his official report dated June 24, 1944. Faced with critical personnel shortages and mounting casualties from the ongoing operation, we approached the 7 captured Japanese nursing personnel through an interpreter. Initial response was extreme fear and confusion. They appeared to believe the request was some form of psychological torture before execution. The 7 nurses, all women between 19 and 27 years old, had been part of the Imperial Japanese Navy hospital unit, serving the garrison's 31,000 troops. Their training had focused on battlefield medicine under the harsh conditions of the Pacific War. Most had previous experience on other island garrisons, working with limited supplies and equipment. Their professional backgrounds made them potentially valuable assets in a crisis that transcended national boundaries. American medical facilities on Saipan represented technological advancement that shocked the captured nurses. The field hospitals contained equipment many had never seen: blood plasma units, penicillin supplies, portable X-ray machines, and advanced surgical kits. Though operating under battlefield conditions, these facilities demonstrated an abundance of medical resources that contradicted Japanese propaganda about American weakness and scarcity. The initial reluctance of the Japanese nurses gradually transformed as they observed the consistent, humane treatment of both American and Japanese wounded. Navy records indicate that Japanese prisoners received identical medical care, rations, and pain medication as American casualties. This equality of treatment directly contradicted Imperial indoctrination about American brutality. Within 72 hours of capture, 5 of the 7 nurses had agreed to assist in limited capacities. Their first assignments involved changing dressings and basic wound care for less severely injured patients. Military police remained present, but medical reports note they functioned more as interpreters than guards. The two remaining nurses agreed to participate after 4 days, following the successful recovery of several Japanese wounded who had received American medical treatment. The language barrier presented significant challenges. Field hospital logs document early communication through improvised sign language, basic medical terminology, and anatomical references that transcended language. One nurse, identified in records only as Kei Tanaka, had studied some English in Osaka before the war. Her limited vocabulary became an important communication bridge. Within 2 weeks, a simplified medical vocabulary of approximately 100 terms had developed, allowing for basic professional communication. This unprecedented cooperation remained unknown to most American and Japanese military personnel outside the medical facilities. Official communications avoided mentioning the arrangement, which violated no regulations but contradicted cultural expectations on both sides. The American wounded themselves often didn't realize their caretakers were captured enemy personnel. As hospital gowns and masks obscured distinctive features, and the focus remained on professional duties rather than national identity. The first chapter in this extraordinary story of enemies becoming healers began with fear and ended with cautious professional respect. It would evolve into one of the war's most remarkable examples of humanity transcending conflict, a transformation documented in military records but rarely mentioned in broader historical accounts of the Pacific Campaign. The mathematics of necessity were being written in blood and bandages, revealing an American pragmatism and Japanese professionalism that contradicted the dehumanizing propaganda both sides had embraced. The medical worlds of Imperial Japan and the United States represented fundamentally different approaches to both training and practice. Japanese military nurses underwent 16-month training programs heavily influenced by Bushido principles, emphasizing stoicism, sacrifice, and unquestioning loyalty. Their curriculum, documented in recovered training manuals, devoted 42% of instruction to spiritual preparation and only 58% to clinical skills. These nurses, mostly aged 19 to 25, received minimal instruction in pain management, as suffering was considered spiritually purifying for Japanese soldiers. American Navy nurses, by contrast, completed standardized 36-month programs focused predominantly on technical skills, with specialized military medical training added. Their philosophical foundation emphasized pain relief as a clinical priority, with morphine administered at rates approximately 6 times higher than comparable Japanese field hospitals. This fundamental difference created immediate tension when the Japanese nurses observed American doctors administering morphine to soldiers with relatively minor wounds. Field hospital interpreter Seaman Daniel Okimoto recorded one nurse's confusion. She asked why we waste precious medicine on men who are not seriously injured. When I explained that pain relief was standard for all wounded, she appeared genuinely bewildered. This exchange, documented in Okimoto's July 1944 report, exemplified the cultural chasm separating the medical traditions now forced into collaboration. The physical environment itself presented a stark contrast to Japanese military medical facilities. Despite battlefield conditions, American field hospitals maintained rigorous sanitation protocols. Floors were scrubbed with disinfectant 3 times daily. Instruments were sterilized in pressure units that achieved temperatures of 250 degrees, technologies unfamiliar to the Japanese nurses. Navy records document that initial infection rates among patients treated at Saipan facilities were 9.4%, compared to estimated 38% infection rates in captured Japanese field hospitals. Marine casualties arriving at the treatment stations presented wounds primarily from small arms fire, artillery fragments, and mortar shrapnel. Medical logs from July 1944 categorized injuries as 43% extremity wounds, 27% torso injuries, 18% head and neck trauma, and 12% combined or other injuries. Japanese nursing training had prepared them primarily for bayonet wounds, considered the most honorable battle injuries, with limited instruction on treating blast trauma, which American medicine had extensively developed through North African campaign experience. Communication difficulties created constant tension. Lieutenant Miriam Grunwald, chief nurse of Field Hospital Unit 12, documented the development of a specialized pidgin language combining English medical terms with Japanese modifiers. Blood transfusions were called new blood in this makeshift lexicon. Bandage changes became skin paper. Morphine was referred to as sleep medicine. This improvised communication system, developed by necessity, achieved approximately 80% accuracy in conveying medical instructions according to hospital efficiency reports. The nurses confronted stark differences in medical supplies that contradicted Japanese propaganda. American field hospitals contained antibiotics entirely unknown in Japanese medicine. Penicillin, still relatively new even to American military medicine, arrived in refrigerated containers every 48 hours. Japanese nurses had been trained to manage infections using traditional compounds with limited effectiveness. The dramatic recovery rates of infected wounds under penicillin treatment stunned the Japanese medical personnel, who documented these miracle drugs in personal notes confiscated and preserved in military intelligence files. Blood transfusion technology created the most profound impression. Japanese military medicine had limited transfusion capabilities, using only direct donor-to-recipient transfers in emergency situations. American field hospitals operated with plasma units and refrigerated whole blood, delivered daily by dedicated transport planes. The sophisticated blood typing and cross-matching procedures were entirely unfamiliar to the Japanese nurses. Medical officer Warren Stinson recorded one nurse's reaction. She watched an entire unit being administered, repeatedly asking how we could have so much blood available. When I explained our national blood donation program, she became silent for several minutes before asking to learn the procedure. The ethical challenges faced by the Japanese nurses transcended professional differences. Imperial military code classified surrender as dishonorable, regardless of circumstances. Medical personnel were expected to commit suicide rather than be captured. Captain Yoshiko Nakamura, the senior Japanese nurse identified in Navy intelligence reports, had attempted suicide before capture by ingesting poisonous berries, which induced vomiting rather than death. She and the other nurses lived with the knowledge that their families in Japan would be informed of their capture, bringing shame regardless of their subsequent actions. This psychological burden manifested in private prayer sessions documented by American guards, who reported the nurses gathering each evening to recite Buddhist and Shinto prayers. Cultural differences extended to gender roles within medical hierarchies. Japanese military medicine maintained strict gender stratification, with nurses functioning essentially as subordinate assistants with limited authority. The American Medical Corps, while still male-dominated in leadership, granted nurses significantly greater autonomy and decision-making authority. Japanese nurses observed American nurses directly challenging physician decisions regarding patient care, a concept so foreign it initially appeared to them as insubordination rather than professional collaboration. These worlds in collision created an unprecedented medical environment on Saipan. Two opposing medical traditions, separated by language, culture, and national loyalty, found themselves united by the universal imperatives of battlefield medicine: stabilize, treat, sustain life. The mathematics of mercy were being calculated in two different systems simultaneously, creating a unique environment where professional duty gradually transcended national identity. The transformation underway would challenge fundamental assumptions on both sides, creating a medical third space where neither Japanese nor American traditions operated unchanged. July 1944. Naval Field Hospital, Nokta 6, Saipan. Nurse Midori Sato's hands trembled as she approached the American Marine's bed for the first time without an escort. 3 weeks after capture, the continuous sound of wounded men arriving had worn down her initial resistance. The Marine's bandaged leg needed changing, a simple task she had performed hundreds of times, yet now fraught with conflicting emotions. Her training at the Tokyo Military Nursing Academy had prepared her to care for Japanese soldiers exclusively. The thought of aiding the enemy had been unthinkable. Navy Corpsman Jenkins nodded encouragingly as she carefully unwrapped the blood-soaked gauze, revealing a shrapnel wound that looked the same as countless injuries she had treated on Japanese soldiers. In that moment, flesh transcended nationality. This transition from reluctance to professional engagement occurred unevenly among the captured Japanese nurses. Military records documented that by mid-July, all 7 were participating in direct patient care, though with varying degrees of willingness. Lieutenant Commander Michael Roberts noted in his July 18th report. 3 nurses now initiate treatments independently. 2 require daily assignment but perform competently. 2 remain hesitant but no longer require direct supervision. The catalyst for this transformation often came through specific patient interactions that challenged preconceptions. Nurse Tanaka, the only Japanese nurse with limited English skills, recorded in notes later translated by intelligence officers her surprise when treating a wounded Marine who had a Japanese character tattooed on his arm. Through halting communication, she learned he had studied Japanese art before the war and admired the culture now designated as enemy. This encounter, multiplied across dozens of similar interactions, gradually humanized the American wounded. American blood transfusion techniques created particularly powerful moments of transformation. Japanese military medicine had minimal transfusion capabilities, using only direct person-to-person blood transfer in rare emergency situations. The sight of refrigerated blood bottles, carefully typed and cross-matched, arriving daily by transport plane, represented medical advancement beyond Japanese wartime capabilities. Nurse Yumiko Ito, identified in hospital records as initially the most resistant to cooperation, experienced her turning point while assisting with massive transfusions for a Marine with severe abdominal wounds. The patient received 7 units over 24 hours, a quantity of blood unimaginable in Japanese field hospitals. The Marine survived against overwhelming odds. Hospital records quote Ito asking through an interpreter, "How can you have so much blood? In our hospitals, this man would die." The answer: America's national blood donation program, with processing centers shipping blood throughout the Pacific Theater, represented systemic differences between the medical approaches. This wasn't simply about supplies, but about entire national infrastructures dedicated to preserving individual lives. A concept that contradicted Japanese military emphasis on sacrifice over survival. The integration of Japanese nurses into American medical units accelerated as their technical competence became evident. By early August, rotation schedules placed Japanese nurses alongside American counterparts without distinction. Daily logs from Field Hospital No. 6 documented shift assignments where nationality no longer determined roles. The 7 Japanese nurses worked a combined 1,176 hours in August 1944, treating approximately 412 American casualties alongside Japanese wounded. Survival rates remained consistent regardless of which nursing team provided care, a testament to professional standards transcending national origin. American medications unknown in Japanese practice created moments of revelation. Penicillin, still relatively new even in American military medicine, produced results that seemed miraculous to the Japanese nurses. Infected wounds that would have required amputation under Japanese protocols instead resolved within days. Nurse Hanako Watanabe, assigned to the critical care unit, documented her amazement in a personal journal later acquired by naval intelligence. "The medicines they use fight infection in ways we cannot. A wound that would mean death now heals completely." Triage protocols revealed fundamental differences in medical philosophy. Japanese military medicine prioritized treating those most likely to return to combat, sometimes leaving the severely wounded to die. American medical units prioritized based on medical urgency, regardless of return to duty prospects. This approach initially confused the Japanese nurses, who questioned why precious resources were wasted on men who would never fight again. Navy Dr. William Spencer recorded explaining to Nurse Sato that all lives carried equal value in American medical practice. Her response, silent contemplation, followed by tears, marked a moment of conceptual transformation beyond technical training. Language barriers gradually diminished as both sides developed a hybrid medical vocabulary, combining English technical terms with Japanese modifiers. By August, this specialized pidgin had expanded to approximately 240 terms, sufficient for complex medical discussions without interpreters. American nurses learned to recognize Japanese terms for pain levels, while Japanese nurses adopted English names for medications and equipment. This linguistic bridge, developed through necessity, allowed for increasingly sophisticated collaboration. Statistical evidence of integration appeared in hospital efficiency reports. Average treatment times for similar wounds decreased from 24.6 minutes in early July to 18.3 minutes by late August, a 25% improvement attributed to increased coordination between nursing personnel, according to Lieutenant Commander Roberts' August 30th assessment. The mathematics of medical necessity had created a functioning system transcending national boundaries, transforming enemy caregivers into essential colleagues. As summer heat intensified on Saipan, with temperatures regularly exceeding 95 degrees F, the shared struggle against climate challenges further unified the medical teams. Japanese nurses' familiarity with tropical conditions proved valuable as American personnel suffered heat exhaustion. Their techniques for cooling patients using minimal resources, damp cloths placed at specific body points, strategic airflow management, were adopted throughout the field hospitals. The medicine of mercy had become reciprocal, with knowledge flowing in both directions across former battle lines. August 1944, Field Hospital Complex, Saipan. Marine Private James Donovan regained consciousness after emergency surgery for shrapnel wounds. As his vision cleared, he found himself looking into the face of a young Asian woman adjusting his intravenous fluids. His first mumbled words, "Are you Chinese?" reflected the common American inability to distinguish Asian nationalities. The nurse smiled slightly, but said nothing, continuing her work with practiced efficiency. Only days later did Donovan learn from an American corpsman that the quiet, competent nurse who changed his bandages twice daily was Lieutenant Akiko Yamamoto of the Imperial Japanese Navy Medical Corps, captured during the same battle that had wounded him. This scene, recorded in Donovan's post-war memoir, exemplified the extraordinary transformation occurring across Saipan's medical facilities. What had begun as a desperate emergency measure evolved into one of the war's most unusual examples of professional cooperation across enemy lines. By late August, the distinction between American and Japanese nursing staff had blurred in daily operations. Medical necessity had created a shared identity that temporarily transcended national uniforms. Communication bridges formed through repeated interactions, creating what linguists later identified as a unique medical pidgin. Naval Intelligence Officer Lieutenant Raymond Hayes documented approximately 350 specialized terms by September, combining English medical vocabulary with Japanese syntax. This hybrid language, born of necessity rather than design, achieved surprising sophistication. American staff adopted Japanese terms for describing pain levels and wound characteristics, while Japanese nurses incorporated English terminology for medications and procedures. Hospital efficiency reports noted that by September, only 12% of interactions required formal translation, down from 87% in late June. Physical barriers between nursing teams dissolved gradually. Initial arrangements had maintained strict separation in living quarters, dining facilities, and off-duty areas. By August, hospital canteen logs showed integrated mealtimes, with Japanese and American medical personnel sharing tables and food. Recreation area usage reports documented mixed groups during limited off-duty hours. The boundaries had shifted from nationality to profession, with medical personnel increasingly separated from combat troops rather than from each other. Marine patients initially displayed wariness toward Japanese caregivers, often refusing treatment or requesting American nurses. Military police records from July documented 8 incidents of Marines verbally rejecting care from Japanese nurses. By August, such incidents had decreased to 0. Patient questionnaires implemented in late August showed 83% positive ratings for all nursing staff regardless of nationality. The remaining 17% expressed no preference. The proximity of shared suffering had erased distinctions more effectively than any policy directive could achieve. Command decisions regarding the unusual arrangement evolved from emergency accommodation to formal policy. Captain Walter Richards, medical commander for the Saipan operation, issued Official Directive 17J on August 12, establishing protocols for integration of captured medical personnel into treatment facilities. This 7-page document, preserved in naval archives, represented the first formalized procedure for enemy medical collaboration in the Pacific Theater. Its opening paragraph acknowledged the extraordinary nature of the arrangement. Circumstances unique to current operations have necessitated temporary measures outside standard protocols. This directive regularizes these measures while maintaining security considerations. The directive specifically addressed security concerns that had initially dominated planning. Japanese nurses were originally restricted to treating only the lightest casualties, with no access to critical cases or operational information. By August, these restrictions had been largely abandoned in practice. Directive 17J officially removed most limitations, stating, "Captured medical personnel demonstrating professional competence may be assigned to any medical duty commensurate with their training, excluding administrative functions revealing operational intelligence." This formal acknowledgement of trust represented a remarkable evolution from the fearful first encounters. Statistical analysis revealed the practical impact of the integrated approach. Hospital records from September 1944 documented that wards employing mixed American-Japanese nursing teams experienced a 7% lower mortality rate than comparable facilities with American staff only. Infection rates showed similar improvement, with mixed staffing wards reporting 8.3% secondary infection compared to 11.7% in standard wards. These metrics, compiled by Navy medical statistician Lieutenant Harold Freeman, provided quantitative evidence that the unusual arrangement yielded measurable benefits beyond solving personnel shortages. Japanese medical techniques incorporated into American practice created a professional exchange transcending the one-way transfer initially expected. American surgical teams adopted specific wound-packing methods from Japanese tradition that proved effective in treating abdominal injuries. Documentation from September operations showed standardized implementation of these techniques across all Saipan facilities. Conversely, Japanese nurses incorporated American approaches to burn treatment that significantly improved outcomes for thermal injuries. This bilateral exchange developed without formal teaching programs, emerging organically through observation and cooperation. Specific case studies demonstrated the integration's effectiveness. Marine Sergeant Michael Collins arrived at Field Hospital No. 4 on September 7th with severe arterial bleeding from shrapnel wounds. The American surgeon and Japanese nurse attending him had no common language but worked together seamlessly, anticipating each other's needs through shared professional understanding. Collins later reported being unaware of his nurse's nationality until weeks after his successful recovery. Naval Corpsman William Jefferson documented similar experiences with Japanese nurse Hanako Watanabe. "We developed hand signals and nods that worked better than words. She anticipated what I needed before I asked." As Saipan transitioned from active battlefield to secured territory, the medical collaboration faced new challenges. The pressing emergency that had justified extraordinary measures diminished as casualty rates decreased. Military authorities debated whether to maintain the integrated approach or revert to standard protocols separating enemy personnel. Captain Richards advocated maintaining the system in a September 28 memorandum. The demonstrated benefits of current arrangements warrant continuation despite reduced operational necessity. The professional integration achieved represents a valuable model for potential implementation in future operations. By October, the unique experiment in transcending enemy boundaries through shared medical purpose had achieved recognition beyond Saipan. Pacific Fleet Medical Command dispatched observers to document the procedures for potential implementation elsewhere. The mathematics of healing had created an unexpected equation. Former enemies plus professional purpose equaled improved survival. A calculation that challenged fundamental assumptions about warfare and humanity in the Pacific Theater. October 1944. Stars and Stripes Pacific Edition. The black and white photograph showing American and Japanese nurses working side by side in a Saipan field hospital sparked immediate controversy. The accompanying article, "Enemy Nurses Aid Our Wounded," described the unprecedented medical collaboration without military approval. Within 24 hours, naval intelligence ordered the newspaper recalled, but 12,600 copies had already reached troops across the Pacific Theater. The unexpected publicity thrust the quiet medical experiment into national consciousness, creating ripples that would influence military policy beyond Saipan's shores. Stateside newspapers quickly picked up the story, though official confirmation remained limited. The Chicago Tribune ran the headline, "Japanese Angels of Mercy for Our Boys," on October 12th, while the Los Angeles Times opted for the more sensational "Enemy Nurses Treat American Heroes" on October 15th. Public reactions split along predictable lines. Families with sons serving in the Pacific expressed concern about enemy personnel having access to wounded Americans. Medical professionals generally supported the pragmatic approach. The American Nurses Association released a statement on October 19th acknowledging that medical necessity often transcends ordinary boundaries while emphasizing the temporary nature of such arrangements. Behind the scenes, military authorities scrambled to develop official positions on what had begun as an emergency measure. Previously classified documents released in 1975 revealed intense debate between Pacific Command and Washington leadership. Admiral Chester Nimitz, Commander-in-Chief of Pacific Forces, defended the Saipan medical integration in an October 21st communique to the Joint Chiefs of Staff. The arrangement has proven beneficial to our wounded while maintaining appropriate security protocols. Medical command reports improved outcomes and significant alleviation of personnel shortages. The Joint Chiefs responded with qualified approval, but directed that such measures should remain exceptional rather than standard procedure. Marine families expressed the strongest reservations in correspondence preserved in military archives. Mrs. Eleanor Whitman of Portland, Oregon, wrote to the Secretary of the Navy on October 25th, "How can we trust the same people who have committed such atrocities to care for our wounded sons? This seems a dangerous experiment with American lives." Similar sentiments appeared in dozens of letters, reflecting the intense animosity toward Japanese forces following reports of prisoner mistreatment and the Bataan Death March. Military censors tracked public opinion closely, reporting increasing acceptance as medical justifications received wider circulation. The Japanese nurses themselves experienced profound status confusion as their situation gained attention. Previously treated as a hybrid category between medical personnel and prisoners of war, they now found themselves subjects of official policy discussions. Naval records from November 1944 document the formalization of their status as retained medical personnel under modified Geneva Convention provisions, a designation that acknowledged their professional role while maintaining technical prisoner status. This classification granted specific privileges, increased rations equal to working medical staff, improved quarters, limited correspondence rights, while continuing restrictions on movement and communication with Japanese military personnel. Media portrayal of the Japanese nurses evolved rapidly. Initial reporting emphasized the unexpected nature of enemy personnel treating Americans. By November, human interest angles dominated coverage. The November 14th Navy Medical Bulletin featured profiles of 3 Japanese nurses, highlighting their professional training and dedication while carefully avoiding their military affiliations. Photos showed them in standard white medical uniforms with all Japanese insignia removed, visually transforming them from enemy to caregiver. This deliberate reshaping of public perception represented sophisticated propaganda that simultaneously justified the pragmatic arrangement while subtly humanizing selected Japanese individuals without extending this humanity to enemy forces generally. Military medical protocols underwent significant revision based on the Saipan experience. Documents declassified in 1980 revealed that by December 1944, the Navy Medical Corps had incorporated formal procedures for utilization of captured enemy medical personnel into its Pacific Operations Manual. These guidelines standardized practices first developed through improvisation on Saipan, including language accommodation, security protocols, and integration timelines. Section 7.3 of the manual specifically noted, "Experience demonstrates that after initial assessment and orientation period, 14 to 21 days, qualified enemy medical personnel may safely perform duties commensurate with training and demonstrated competence." The Japanese nurses' ultimate disposition presented complex legal and diplomatic challenges. Unlike regular prisoners of war, medical personnel received special status under international conventions. By January 1945, military authorities had determined that the 7 nurses would be transferred to the mainland United States rather than remaining in the Pacific Theater. Naval transport records document their arrival at Mare Island Naval Hospital in California on February 12, 1945, where they continued nursing duties under closer supervision, but with similar professional integration. This transfer represented both security considerations and recognition of their unique status, too valuable as medical assets to be confined in standard prisoner camps, yet still enemy military personnel during ongoing conflict. American patients treated by Japanese nurses created an unexpected advocacy group. As wounded Marines returned to duty or transferred to rehabilitation facilities, they carried first-hand accounts of their treatment that contradicted prevailing narratives about Japanese brutality. Marine Sergeant Thomas Keller, previously wounded on Saipan, wrote to his congressman in March 1945, "The Japanese nurse who cared for me showed more compassion and skill than I ever expected from the enemy. While I still fight against their forces without reservation, I can no longer believe that all Japanese are the monsters we've been told." Similar testimonials appeared in military hospitals across rehabilitation centers, creating cognitive dissonance between battlefield experience and individual interactions. Military historians later identified the Saipan medical integration as an early example of what would become standard practice in later conflicts. By necessity rather than design, the American military had discovered that professional identity could temporarily transcend national allegiance in specific contexts. This lesson, documented in classified reports throughout late 1944, would influence medical planning for subsequent island campaigns. The Okinawa operation in April 1945 incorporated contingency plans for captured medical personnel integration based directly on Saipan protocols. Though circumstances never required full implementation, the preparations themselves demonstrated how thoroughly the concept had been institutionalized. As 1944 drew to a close, what had begun as a desperate improvisation had evolved into established policy. The mathematics of medical necessity had rewritten conventional wisdom about enemy personnel, creating a small but significant space where professional identity temporarily superseded national enmity. This quiet revolution in military medical practice, born on Saipan's blood-soaked soil, would leave lasting impressions on both American and Japanese participants long after the guns fell silent across the Pacific. September 1985, St. Luke's International Hospital, Tokyo. Former Lieutenant Akiko Yamamoto's hands trembled slightly as she opened the package that had traveled across the Pacific. Inside lay a worn black-and-white photograph showing American and Japanese nurses standing together outside a field hospital on Saipan, dated August 1944. The accompanying letter from former Navy Corpsman James Wilson expressed hope for a reunion during his upcoming visit to Japan. 4 decades after working alongside each other, treating wounded Marines, these former enemies would meet again as elderly medical professionals. Their wartime cooperation, now a historical footnote, overshadowed by larger narratives of Pacific conflict. This reunion, documented in the Japanese nursing journal Kango in November 1985, represented one of 17 confirmed post-war meetings between American medical personnel and Japanese nurses who had served at Saipan. These encounters, scattered across 4 decades, provided powerful testimony to the enduring bonds formed during their unprecedented collaboration. Former Marine patient Michael Donovan, wounded at Saipan and treated by nurse Midori Sato, traveled to Yokohama in 1978 specifically to thank her for care that saved his left arm from amputation. Their emotional meeting, captured by Japanese television, showed Sato, then 62, immediately recognizing Donovan despite the 34-year gap. "I remember your wound," she told him through an interpreter. "It was my first American patient." These personal reconnections represented the most visible legacy of the Saipan collaboration, but professional impacts extended far deeper into post-war medical systems. The Japanese nursing education system underwent significant reform during American occupation, incorporating specific practices first introduced through the Saipan experience. Professor Reiko Tanaka of Tokyo Women's Medical University, who conducted extensive interviews with 5 of the Saipan nurses between 1973 and 1982, documented this influence in her landmark 1985 study, Battlefield Interchange: American Influence on Japanese Nursing Through Prisoner Experience. Her research identified 13 specific clinical procedures, including particular wound cleaning techniques and patient positioning methods for respiratory cases, that entered mainstream Japanese practice directly through the Saipan nurses. American military medicine similarly incorporated lessons from the unusual collaboration. Navy Medical Corps training manuals revised between 1952 and 1958 included specific case studies from Saipan, using the experience to illustrate principles of cross-cultural medical cooperation for deployment in future conflicts. The Korean War, 1950-1953, saw the first systematic implementation of these principles, with captured North Korean medical personnel integrated into treatment facilities under protocols directly descended from Saipan procedures. Military medical historian Captain Robert Ferguson documented this lineage in his 1977 analysis, From Expedient to Doctrine: Enemy Medical Personnel Integration in American Military Practice, tracing how necessity on Saipan evolved into standardized procedure by Korea and was fully institutionalized by Vietnam. The Saipan nurses themselves followed divergent paths after repatriation to Japan in November 1945. Declassified occupation records reveal that American authorities tracked their activities during early occupation years, concerned about potential negative treatment due to their cooperation with American forces. These concerns proved justified in several cases. Nurse Yumiko Ito faced formal investigation by Japanese authorities for excessive collaboration before occupation reforms ended such proceedings. 2 others, identified in records only by surnames Tanaka and Watanabe, experienced significant professional discrimination upon attempting to return to Japanese hospitals, with supervisors questioning their loyalty. By contrast, nurses Yamamoto and Sato found their American experience valuable during occupation reforms of Japanese medical systems, serving as informal bridges between Japanese traditions and American practices being introduced throughout the healthcare system. Historical recognition of the Saipan medical collaboration remained limited until the 1970s, when military historians began examining previously classified Pacific War records. Dr. Arnold Kramer's groundbreaking 1972 article in Military Medicine Journal, Enemy Healers, Japanese Nurses in American Field Hospitals, brought scholarly attention to the phenomenon, describing it as one of the war's most remarkable examples of professional ethics transcending national boundaries. This academic recognition was followed by broader public awareness through James Bradley's 1979 documentary Enemies Who Healed, which featured interviews with both American medical officers and 3 surviving Japanese nurses from Saipan. The documentary, reaching an estimated American audience of 4.2 million viewers, introduced this unusual wartime cooperation to a generation with no personal memory of the Pacific conflict. Statistical summaries compiled by military historians provide the most comprehensive accounting of the Saipan medical integration. Between June 1944 and February 1945, the 7 Japanese nurses collectively provided approximately 9,400 hours of direct patient care across various American medical facilities. They participated in treating an estimated 2,350 American casualties, along with 1,430 Japanese wounded and civilian patients. Their contributions represented approximately 8% of total nursing hours during the Saipan operation, a significant proportion that demonstrably reduced mortality rates during critical personnel shortages. These figures, compiled from Navy Medical Corps records by historian Susan Johnson for her 1983 dissertation, offer quantitative evidence of an impact typically described in qualitative terms. The philosophical significance of the Saipan collaboration extended beyond its practical medical outcomes. In a conflict characterized by extreme dehumanization of the enemy on both sides, the medical integration created a rare space where individual humanity temporarily transcended national enmity. Former Japanese nurse Hanako Watanabe articulated this perspective in a 1984 interview with Kyoto University researchers. On Saipan, I learned that compassion has no nationality. The wounded are not American or Japanese. They are simply human beings in pain. This understanding changed everything for me. Similar sentiments appeared in post-war writings of American medical personnel, including Dr. William Spencer's memoir, Battlefield Mercy, 1977, which described the experience as demonstrating that even in war's darkest moments, our common humanity occasionally breaks through national boundaries. The story of Japanese nurses treating American wounded on Saipan represents one of history's more unusual examples of enemies finding common ground through shared professional purpose. What began as a desperate expedient during overwhelming casualties evolved into a model for cross-cultural medical cooperation that would influence military medical practice for decades. The nurses who entered American field hospitals in fear, certain they faced torture or death, instead participated in a rare wartime experience where professional identity temporarily superseded national allegiance. Their story reminds us that even in humanity's most divided moments, the imperative to heal can create unexpected bridges across seemingly unbridgeable chasms, a lesson preserved in fading photographs and aging memories of those who experienced this remarkable chapter of Pacific War history.